Hello, welcome to NAHUD's series, Bridging HIV and SUD Innovations in the Field. My name is Ashley Johnson and my pronouns are she, her. We invite you to use the chat to engage with your fellow attendees. Drop your name, organization, and favorite ice cream flavor. Throughout the session, please use the Q&A pod to ask your questions. The speaker will address them at the end of the presentation. Today's session will be recorded and a PDF of the presentation slides will be added to NAHU's website as a resource. You will receive this information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find this resource and view past sessions. NAHUD is a membership organization of 8 regional and 2 national AIDS Education and Training Centers, AETCs, that support the AETC program mission. Established in 2010, NAHUD supports the AETCs, a component of the HRSA-funded Ryan White HIV and AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations in order to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and other substance use disorders through the provision of locally designed education and training. Visit the website to submit a TA request, read case studies, see featured resources, check out upcoming ORN events and trainings, and learn about ORN work groups addressing health disparities and more. There will be a post-evaluation survey that will be emailed to you after today's webinar and must be completed within 2 weeks to receive CME, CNE, Social Work CE, or a certificate of attendance. After 2 weeks, once the survey is closed, it will not be reopened. The minimum attendance required to receive CE is 60% of today's webinar. That's 36 minutes. Participants who accrue less than 60% will not be eligible for CE. Certificates will be emailed within 3 weeks of completing the evaluation. CE credits issued for participation may not apply towards license renewal in all states. It is the responsibility of each participant to verify the requirements of their state's licensing boards. Dr. Francine Cornos will present today's session, Triply Diagnosed. Dr. Cornos is a professional of clinical psychiatry and epidemiology at Columbia University and co-principal investigator of the Northeast Caribbean AIDS Education and Training Center. She has worked at the interface of HIV infection and mental illness since 1983, both locally and globally, in the areas of clinical care, education, research, policy, and guidelines. In the course of these activities, Dr. Cornos has published more than 180 articles and book chapters. Without further ado, I will turn it over to Dr. Cornos.
Thank you so much for inviting me to give this talk today. I have been an attendee of many of the previous talks that have been given in this series. So I want to also just start with a disclaimer that the talk that I'm giving is just trying to figure out how to advance. That the talk that I'm giving is a little bit different than some of the other talks that have been given. And the reason for that, Hmm. Advance. Excuse me, I'm just having trouble advancing.
You may be able to use your arrow or your enter. Uh,
My arrow or my enter. Normally an arrow appears, but I don't see it this time.
or if you click on it, it doesn't advance.
No, maybe
Maybe
it's best for someone do you want to do it for me? Only because for whatever reason, normally an arrow appears that allows me to advance, but I don't see it here.
yes.
Hold on, wait, maybe I do now. Okay,
There
all
it
right.
is.
Yeah, I'm sorry, it didn't show up right away. I'm sorry. Anyway, excuse me, audience, for wasting a few minutes. I wanted to say that I've been to a lot of these talks, and my objective today is to give a somewhat different talk rather than focus on specific pieces of evidence about how to treat triply diagnosed patients. I'm going to try to provide an overview of what do you do when you're trying to introduce evidence into a world that's fairly chaotic. So the evidence speaks for itself and it's often very good, but the world we're applying it in is very uncertain and difficult and varies greatly from one part of the United States to another. My hope is to convey why, in the person with triple diagnoses, everything is integrated in that individual, but in our healthcare system, nothing is well integrated for the most part. So, how do you understand what to do in your unique circumstances? And that's my focus. It's about your own creativity in uniquely thinking about where you work, and how you will apply evidence given your own facilitators and barriers. For example, I ran a program in New York City, in Manhattan, that's going to be very different than a program that's taking place on the Texas-Mexico border. Um, I was already introduced, but I just want to say that I have a background that is more administrative than anything else, which is why I would like to give this systems perspective. I've been doing work all over the world, and it's been very illuminating, although I'm only focusing on the US. It's been very illuminating to see how a totally different country approaches the same set of issues that we have. He has a question to think about, and I'm going to address it later on. So in 2021, the leading cause of death in the US among people with ages 25 to 44 who had HIV was the HIV disease itself. It's a cause of mortality in 33% of those who died. What was the next most common cause of death? And your choices are cancer, heart disease, overdose, COVID-19, and hepatitis C. And I will get back to that question. Let's start out with a definition. Triply diagnosed in this talk refers to people with one or more alcohol or substance use disorders, one or more other psychiatric diagnoses, and HIV. But we know that with those three diagnoses, there are many other diagnoses that travel in addition to that. And I'm not going to have time to go into that. There are multiple barriers to care integration. That is my focus, although it's impossible to cover everything that's relevant to that. But we know that we have a healthcare system that is relatively dysfunctional, and that each of the three diagnoses that we're trying to treat is stigmatized. And those are huge barriers. Here's a famous person who had a triple diagnosis. I actually am sufficiently old that I was able to see him dance in my youth. Alvin Ailey, he was a remarkable modern dancer. He had alcohol and drug use disorders, bipolar disorder, and HIV infection. And he died in 1989 of AIDS, but his work lives on. And the reason why I mention him is because, in addition to thinking about the pathology of people who have mental disorders, including drug use, and in this case, bipolar disorder, we also want to think about the assets that these people bring. There are many creative people who have significant mental health and substance use problems, and it's important to understand and respect just how strong some of these people are in terms of what they can do with their lives. And here's one more person with a triple diagnosis. And I just want to say that probably for those of us who haven't had a triple diagnosis, it's not easy to imagine the inside of the brain of someone who's doing that. So I just put in a few quotes, and I will only read the first one. Here's what he says about the inside of his brain. You borrow my brain for 5 seconds and just be like, dude, can't handle it. Unplug this bastard because, yeah, it fires in a way that is maybe not from this particular terrestrial realm. So the state of having drugs in your body and having a mental illness is not easy to describe, and is very complex. Mental disorders just simply track with HIV. And they always have. They're a risk factor for becoming infected. They're an outcome of learning you're infected. They're a comorbidity. And that's because as people get more medically ill, they also develop more mental illnesses, and they're a cause of morbidity and mortality. So mental disorders pervade HIV, from risk for HIV through the entire spectrum of care. We know that mental health conditions often precede HIV infection, and this is just one study of about 4,000 men who have sex with men in 6 cities in the US. And they looked at 5 factors, the first one being depressive symptoms, the next 3 being substance use, and the third being an adverse child event, in this case, childhood sexual abuse. The more conditions a person had, the less likely they were to remain HIV negative. So when we're thinking at the outset about prevention, we're also thinking about what do you do at the beginning of the onset of these conditions, and what do you do about traumatic events that put people at increased risk. I'm going to just mention that we have a diagnostic manual, and in common parlance, we're used to separating out substance use disorders and mental illnesses, but that's not how diagnostic manuals work. So whether you're using the diagnostic and statistical manual that we use in the US, or you're using the International Classification of Diseases, which is the World Health Organization's manual, we are calling all of these conditions disorders. They're all mental disorders. And in the absence of biological tests for most mental disorders, their definitions keep changing. So we probably have more stable definitions of, of many medical conditions than we have of mental health conditions, because we don't understand them well, and we keep using evidence to update our definitions. Before there were any manuals to describe mental illness, there were definitely lots of people who had mental disorders, and it's hard to say exactly what they had, but I just put up the pictures of 2 artists who are very famous. Edvard Munch, that's his picture called The Scream, which has been repeated almost everywhere in the world in numerous forms. And this is Van Gogh with his self-portrait. These were people who had mental disorders, but they didn't have diagnoses that were official because we didn't have any manuals. Here's our latest manual. It's only 1,050 pages long. It has everything that you can imagine in it. That includes, not only substance use and alcohol, but every mental disorder, and also developmental disorders that you see in children, cognitive disorders. Everything in it is in there. Everything is considered a mental disorder. But the problem is that regardless of how many pages we write about how to diagnose people, we really are at the frontier of understanding the brain. The brain is the least understood organ in the human body. We're looking at it in various ways: cell types, neural networks, neurotransmitters, developmental trajectory. But the brain, it has 86 billion neurons and 100 trillion synaptic connections. And the mind resides within the brain, and it's utterly unique from one person to another, and that's even true for identical twins. Every one of you who's listening to this talk has a brain that's not like any other person who's listening to this talk. And likewise, every person who walks into your office, client, patient, whatever you call them in your setting, has a brain you have never seen before. And this makes work with patients very challenging, but also we need to be very creative. And I think the most fun part of being in a field with so much uncertainty is the fun of being creative and understanding that there's a lot we don't understand and we need creativity to make our evidence work. So I've already said that, in our system, we don't have integration of care. We have huge variation across the US in terms of, what's funded and what's not funded, what kind of insurance, what's available locally, what's not available, what happens in rural areas, urban areas. And we also have evidence that we're only at the beginning of collecting in many areas of mental health. So we're just beginning to understand the brain, really. And because we deal with so much uncertainty, we're applying evidence in a world that's chaotic. So the best programs are the programs that create practical solutions that are tailored to the reality of your own time and place. You who are listening to this talk know much better than I do where you are, what setting you're in, what's available, what works, what doesn't work. Your creativity will make all the difference in whether we can use the evidence we have in an effective way. It's also very natural that substance use disorders and other mental illnesses travel together because they have common underlying genetic, environmental, and socioeconomic vulnerabilities. Because once you have a mental illness, you can start self-medicating with alcohol and substance use and other substances. And once you have a substance use condition, you can have both use and withdrawal leading to symptoms of mental illness. So I'm going to give an example. I don't have time to give all the examples that I could, but this is just anxiety. Let's say you're seeing a person who has anxiety. That person might have an anxiety disorder, but that person could have numerous other things. And anxiety is associated with substance use. So I've listed the substances that cause anxiety and the ones when you use them and ones that cause anxiety when you're withdrawing from them. So when a person has anxiety, the first thing you want to think is, this is a very complicated symptom. It could be related to substance use. It could be related to physical illness. This is a mystery. Why is this person anxious? Behavioral health has been overcredited with the idea that it can answer the questions as to what's wrong with people or be available to figure out what's wrong with people on all occasions. This is absolutely unrealistic. We have a very small mental health workforce compared to the scope of the problems we have. Every healthcare provider needs to be involved, no matter what your background is, in trying to figure out the mystery of what's wrong with the patients that we see who have triple diagnoses. The brain and the body and the mind are completely connected because when you think about it, our brain is controlling all our essential involuntary bodily functions. How fast we breathe, how fast our heart beats, all of that, the brain is giving messages to the body about what to do. And the body, and in turn, the brain is telling the body what to do, but the body is giving feedback. So let's say you're eating food, the body tells you when you're full. If you're lucky, the body tells you when you're full. Or let's say a lion is chasing you and you're running away. You'll notice, however, when your muscles are getting tired from doing that. So the brain and the body are completely integrated. It has nothing to do, we make categories, but the categories have nothing to do with the integration, which is complete inside the person with triple diagnosis. And we know that emotions are brain, body, mind phenomena. And I'm just listing some of the many expressions that we have in the ordinary English language that convey this. I had a gut feeling, a lump in my throat, a knot in my stomach. It made my blood boil. When you think about how we speak in ordinary English language terms, we know the brain and the body and the mind are all integrated. We just don't have a system that accommodates them. So now I'm going to go on to talk about clinical care and care systems. I want to start out by talking about our switch from focusing on mental illness to mental wellness. Ever since COVID, we have had a dramatic increase in thinking about mental wellness. And that was because during COVID, there was so much distress among healthcare providers and their patients. And if you look at studies about the impact of COVID-19, there are actually more studies about how terribly it affected healthcare providers than there are about how terribly it affected patients, because healthcare providers were on the front lines in the beginning of this epidemic and were highly traumatized. As a result of the trauma that healthcare workers experienced, and the people who, and their families who were facing COVID, mental wellness became a very big area that we talk about. But mental wellness is not specific to the profession of behavioral health. It's really the province of all healthcare team members. And that is what I hope to convey that in this talk, that you, regardless of the role that you play a role in the mental wellness of every person that you see. So let's consider the difference between mental distress and mental disorders. Anything can give you mental distress. You could have just had a fight with your daughter and be distressed about that. Anything at all. That doesn't mean you have a mental disorder. So often people come in a state of distress to see you, but it doesn't mean they need a behavioral health provider to deal with the stress, because it depends on what it is. So let's say a client comes into your office, he's just gotten an eviction notice. That's not a person who needs, and he's very distressed about it. That's not a person who needs a behavioral health provider to deal with the distress of getting an eviction notice. That's a person who needs somebody who understands how to fight eviction and how to access housing resources. So that's why distress is everybody's domain. It's very deeply connected to the social determinants of health, and it falls into all providers. Whereas mental disorders are things that cause severe subjective distress and functional impairment, and they meet criteria either in the International Classification of Diseases or the Diagnostic and Statistical Manual. They call for evidence-informed mental health interventions, such as medication, psychotherapy, brain stimulation, and so on. Mental distress is everybody's province, everyone's problem, and everyone's problem. If you're working on the front lines and you don't know if someone is just in distress and has a disorder, you can screen for mental disorders. And I'm not going to spend much time on this, other than to say that it's very easy to screen for mental disorders if you have the time to do it. We like to choose practical tools that are short, easily scored, free, and that you don't need training to use. And I worked on this curriculum. This is the HIV National Curriculum. I worked on the mental health tools but not the substance use screening tools. And you'll see here that there are mental health tools for anxiety, depression, and PTSD that have automatic calculators. What that means is that whether you're trying to figure out your own diagnosis or your client's diagnosis, you can go to one of these tools that has an automatic calculator. You ask the questions, you put in the answers that the patient has, and it tells you what the probability is that a person has a mental disorder. And I've already said that there just aren't enough healthcare providers there aren't enough of either healthcare providers or mental health care providers to think about distress as something that belongs in the province of one group of people. One approach that we've seen is being bombarded with a set of handouts and tools and advice about how to cope with ordinary distress or the normal things that happen in life that cause distress. So I'm just going to mention one resource. There are numerous ones, but this is the Veterans Administration Whole Health Approach to Managing Distress. And they have a lot of handouts that go from everything to managing grief, having a gratitude practice, meditation, breathing. And anybody is capable of accessing these handouts and understanding what they say. whether you're doing it for yourself or you're doing it for a client that you're working with. So remember, you don't need a behavioral health provider for this. There are lots of tools available that are for the public. When I did my international work, I came across a framework called the World Health Organization Pyramid of Mental Health Services. This made my work, I did a lot of work in sub-Saharan Africa. This made my work there much more comprehensive and comprehensible to me, because sub-Saharan Africa is a place with very few mental health providers. So this pyramid allowed me to understand that to keep somebody well who's at risk for has a psychiatric diagnosis, you want to think about every level of care that's needed for it. You want to think about the patient's own self-care. In the end, whether the patient does what's needed for self-care is the most important determinant of whether they will stay well. Unfortunately, it's not us. It rests with the patient's own self-care. In every community, there are informal supports, churches, for example, and these supports are very important to keeping people well. So it's extremely important to know the informal community care supports. Then we get to primary care services, which is probably where most of the people on this talk today are doing work. And in primary care, we screen and we can refer up to the specialized services. The specialized services are in the top of the pyramid. They are the most expensive and the least available. We need a holistic approach that recognizes that behavioral health providers don't have a solution to how to provide care to triply diagnosed people operating in a healthcare system that's chaotic and disorganized. And I think that that means that if you're working in any setting, in any capacity, and if you can help your patient solve some of the problems that we know interfere with receiving care and accepting care and adhering to care, whether it's food, shelter, income support, transport, social support, people transitioning from prison to the community, that it's so important to understand that to treat triply diagnosed people, we need everything. Every attempt to address a social determinant is going to contribute to keeping people with triple diagnoses well and accepting of care. We have unduly focused on addressing mental disorders on the grounds that you need to address them to achieve viral load suppression. This was a wonderful and remarkable thing when the ideas were first introduced, but we're more than 10 years out of that pyramid of that set of components of the diagram of HIV care, from diagnosis to treatment to viral suppression. And we know that it's not really a great match for our goals in 2024. Because in 2024, we're interested in preventing new HIV infections. And if you don't have an HIV infection, you don't have a viral load to measure. Therefore, mental health interventions that are aimed at preventing people from getting HIV infected aren't going to be able to use viral loads as a helpful sign, other than to see if, in fact, the prevention has failed. We also know that as people age with HIV, the exclusive focus on whether they have a suppressed viral load is very annoying to peers and people with HIV infection who are aging and need care for multiple conditions and often are not getting it. If you listen to what peers have to say about aging with HIV and how little focus they get on areas of life that would make them increase the quality and meet their needs, it is huge. What goes beyond viral suppression and is often left unaddressed. And narrowing the morbidity and mortality gap between people with HIV and people without HIV is another thing that we are working on doing, whether or not someone has HIV with viral suppression or without viral suppression. Basically, the people are still dying significantly younger than the general population, despite the excellence of our HIV treatment. We have to think about that gap in morbidity and mortality in the triply dosed diagnosed population and what we can do to improve that. One way to think about this problem is to consider, that I've been talking about, is to think about behavioral health and health behavior. So I'm a trained behavioral health provider. Some of you on this call are also. And we have strategies to treat mental disorders as they are defined in the DSM and the International Classification of Diseases. And we also want to reduce subthreshold symptoms in people that we know have recurrent illnesses. So most illnesses are in psychiatry are chronic and relapsing. So take depression, which is one of the most common illnesses that we see in triply diagnosed people. Depression can be in remission, and when symptoms start to return, even when they're sub-threshold, we worry, could this person go into a full episode? That's a sign we have to intervene before the full episode develops. That's what we do in behavioral health. We track people with chronic condition. We track whether they're starting to relapse and what we can do. We also know that there are targeted strategies that can prevent the onset of mental disorders in specific groups of people. So, for example, we know that young people have very malleable brains and are much more susceptible to the toxicities of using drugs, whether it's marijuana causing psychosis or amphetamines causing psychosis. The younger you are, the more flexible your brain is, the more vulnerable you are to having drug use precipitate another mental, drug use precipitate another mental illness. Health behavior is what everyone has to pay attention to. This is about how the patient sees things. This is what the patient's understanding is of their medical diagnosis and recommended treatments, and the patient's own barriers and facilitators to carrying out treatment recommendations. We can work with people on reducing their unhealthy behavior, but people often get very frustrated. I ran a program for people with severe mental illness. So people mostly had schizophrenia and bipolar disorder. They had a lot of infectious diseases. They used a lot of substances. And I can say that one of the things that kept me sane while I was doing that was to understand that it's a very slow process and not to get frustrated, because helping people change unhealthy behaviors, which are the most important factors in premature mortality, is a very difficult thing to do, and it takes a lot of patience and repetition. Having a single discussion with the patient won't change anything. If people are smoking, or they're following a poor diet, or they don't exercise, or they take undue risks, telling people not to do those things doesn't have much impact. It is a conversation that takes place over a very long period of time. That's the only way we can get people to behave in healthier ways and keep them alive. What are the general principles about caring for people with 3 diagnoses? The ones that I like to use is that 3 diagnoses need 3 treatments. Even though it's true that sometimes when you treat one diagnosis, others might improve, the fact is that 3 diagnoses need 3 treatments. And non-adherence is human nature. As people opt for other life priorities, the patient's going to have the final say. So here you are with a patient with 3 diagnoses. You're trying to get them to accept 3 treatments, one for HIV, one or more, depending on the number of substance use disorders, and the same, because people can have multiple other psychiatric diagnoses. So you're trying to get people to follow through on very complex regimens. But sadly, most humans don't think that that their healthcare is the number one priority in their lives. I've had people come into emergency rooms when I was doing medical care and they're bleeding to death from an internal gastrointestinal bleed. And I tell them that they need to come into the hospital for life-saving blood transfusions. And they say, no, I can't stay here. I have to leave to do something else. And from the beginning of my medical career, when I saw that happen, I understood that patients going to have the final say, except for the small group of people who are sufficiently incapable that they have someone who is considered the person making decisions for them. We have a lot of evidence and a lot about systems, but one size does not fit all. The uniqueness of your circumstances need to determine what you're going to do about people with triple diagnoses. You have to create your own best locally driven practical model. I'm going to skip this slide in the interest of time. So in any setting that you're working in, you want to think about the fact that whatever the job is that you are doing, it's a piece of something much more complex. And you want to think about what pieces can you engage in. So if you're seeing someone for, let's say, HIV care, you could consider screening for alcohol and substance use disorders or other common mental illnesses. And that would allow you to understand who are the people who really do need a referral to behavioral health providers. You can also, if you're a federally qualified health center, get licenses to do multiple things. Although even then, it's still very hard to integrate care and very hard to take care of people with the most severe mental illnesses. And because the patient is going to have the final say in under almost all conditions other than patients who are committed to a psychiatric hospital, and they will have the final say once they leave, you want to understand that education and shared responsibility is the only way you can go. Patients are going to determine what they do, not you. We need a very slow process by which we educate them, listen to them, and understand them. I want to say that the biggest gift you can give to a person that you're seeing is to listen to what they have to say non-judgmentally. I tell this to my residents who are starting to train in psychiatry. You don't need to know a lot of facts. Listen and acknowledge what you're hearing. Doing that is one of the greatest gifts anybody gives to another person when they're in the healthcare field. We know there are numerous prevention strategies that go back to early childhood. If we really wanted to prevent triple diagnoses, we'd start out by addressing the adverse childhood events and all the things that go wrong. And as soon as somebody had one diagnosis, we would try to prevent other diagnoses. Prevention is a huge piece of trying to get people to not reach the place where they have all three diagnoses. I wanted to talk about morbidity and mortality. I have discovered, as a psychiatrist trying to get people to pay attention to why people die from mental illness, that it doesn't help to talk about disability. We know that mental illness is very disabling, but as best I can tell, the only reason why the World Health Organization and the United Nations decided to pay attention to mental illnesses is because they also kill you. So tobacco is number one thing that kills people. And it was the leading risk for health loss in 2019. In the US, we've seen incredible increases from drug use disorders in deaths. And it's been estimated by The Lancet, but I don't know that this is a true estimate. I keep thinking maybe other countries don't have good evidence, that more than half of all overdose deaths occurred in the US. It takes going in the whole world. It takes going to other countries, which maybe some of you had the fortune to do, to understand how bizarre our healthcare system is, how fragmented, how unresponsive it is. And sadly, we just got evidence from the largest US community-based cluster randomized trial using multiple evidence-based practices to reduce opioid deaths. And you can find that in the New England Journal of Medicine. It was a study of the healing community. there were no statistically significant differences between experimental sites and control sites. To me, what that says is that everybody is working in such a unique and chaotic environment that our evidence has to be applied in ways that take into account a multitude of factors. We are not going to solve the problem of triple diagnosis easily. There's no simple solution that someone's going to give you because they have a new piece of evidence. Smoking kills. This was a study conducted in Denmark. It looked at almost 3,000 people who were over age 35. And in Denmark, you know everything about everybody. It's really a remarkable country. All the Scandinavian countries, they know if dogs were barking, near you, and if you had a lot of noise when you were growing up. It's remarkable. Anyway, that's why studies from Scandinavia are so remarkable, because they know everything about the population and because care is free. So you don't have to get insurance to get care. So therefore, you're not worried about access to care when you're looking at why people die young. Everyone has access. Okay. In this study, people with HIV lived 5 years shorter than the general population, but people who smoked and had HIV lived 12 years less than the general population. Adding smoking to HIV is one of the big killers of people with HIV infection, and smoking is a substance use. Skip that. I've listed a variety of problems that are connected to mortality related to HIV infection. These are the most important ones. And I'm going to just very briefly talk about the fact that everyone needs to be comfortable. No one should be able to graduate from any degree program, in my opinion, unless they're comfortable being with someone who is not in a normal mental state. Because the onset of an abnormal mental state occurs in every cause of thing that kills you. Anything that can kill you makes your mental state abnormal. Whether it's a low blood sugar, infection, kidney failure, you name it. And therefore, unrecognized delirium, and I've seen it everywhere in the world I've gone, unrecognized delirium that's sent to behavioral health before people rule out medical conditions causes premature death. I've seen it everywhere in my own setting, at Columbia, and in every setting I've been to internationally. It's fatal to prematurely refer people with delirium without doing a medical evaluation to behavioral health care. This is the answer to the question I asked. If you look at the red bars, what they're going to show you is that in 2010, a little more than 60% of people were dying of HIV disease. By 2021, that number had dropped to only 33% of all deaths were attributable to HIV disease. So the second cause of death was overdose, and that's the hatched blue bars right above the red bar. Overdoses went to 18% of deaths in people ages 25 to 44 in those with HIV infection. So that's what we're dealing with. We're dealing with death from overdose as starting to catch up with death from HIV itself. That's what I just said. Suicide is still a prominent problem in the HIV population. And there was someone recently who did a study of all the studies that have been done about suicide. And we all were paying attention to suicide early on in the epidemic when we didn't have treatment. But guess what? Suicide continues to plague us, even with good treatment. So the studies that were looked at were global in this review. There were 53 US studies. The most common risk factors for suicide are depression, substance use, right? So there's your triple diagnosis, but also low quality of life and low social support. We've heard more and more about loneliness and low social support and how it diminishes the quality of life and leads to the end of it. These are social determinants of health, and they play as much of a role in suicide as do the actual disorders that we're talking about. So you can see the attempted suicide rates and completed suicide rates are still significant in the HIV positive population. Everything we do that ameliorates a social determinant of health is helpful to the person with a triple diagnosis. The way I learned to do this in Africa, where there was much less available, is when I got to a site where I was working, I learned everything that was available at that site. Every single benefit, where people could get food if they were hungry, what to do with housing, how to get people transported from one place to another, what to do with people struggling with legal problems. It didn't matter what it was. I understood that every single thing I did that addressed a social determinant of health was going to keep people with triple diagnoses safer and more likely to survive. I also know that reaching out to peer workers and community health workers are really important. Community health workers are there in the community to see everything that's taking place in that specific community. That's what you need to know. So I'm going to end with these conclusions. The brain and the body are one. There's nothing separated in the person with triple diagnoses about each of these diagnoses. But we don't have a healthcare system that works. We are implementing evidence in a chaotic world where every state, every territory, every provider, every area has its own rules, its own limitations, its own barriers. It's going to take a village for us to solve this problem. It involves every one of you listening to this talk. We have to advocate for improvement in our healthcare system. We have to maintain a moral compass. I can't tell you how distressing it is to read about physicians not providing healthcare to somebody because they might get sued and letting someone die. I'm sorry, if I have a patient who's dying, I'm going to intervene and worry about being sued later. You have to have some agency. We can't be passive. We can't follow every directive that we're given that can harm patients or waste time. If you're on an assembly line where the only goal of the corporate organization you're working for is to make money, that can't be what you carry out. But you have to let the patient come into your office and deal with the problem the patient has. If the corporate system wants to be able to collect more money, let them provide adequate service. We need common sense. I survived doing work in many very frustrating settings by having strong ties between team members to foster a sense of joy and purpose. That's what we need. We need joy and purpose as we fight an incredibly complex battle of treating people with triple diagnoses. And that's where I'm going to end. So I have time for some comments and questions.
Thank you so much, Dr. Cornos. We do not at the moment have any questions, but I do see that an attendee had a hand raised. If you would like to unmute yourself and ask your question, that would be great.
So I see Carissa has a
Rissa.
question. Do you want to unmute yourself to ask it?
The hand has come down, so maybe that was an accident. Yes, it
Well,
was.
I would love to hear from you if you wouldn't mind some of you talking about what you find to be the frustration and barriers of working with people with triple diagnoses and what you think of my idea that you really need to be very creative in your immediate world in order to be able to carry out evidence. It isn't the same from one place to another. And it's really, I don't know if we're going to create a saner healthcare system. I really hope that we do. I didn't mean to leave you all speechless.
No, you're getting a lot of praise
Patient
in the
care.
chat.
I see there are some comments. So, you know, you're right. Every patient you're working with. So this is, well, I'm going to just say something personal about myself. I was, I suffer from a mental disorder. I like to mention that because I have like a one-person mission to reduce the stigma of mental illness. So I am a functional person suffering from, I had actually quite a few mental disorders when I was a child. I had many adverse child events. I was orphaned. I lived in foster care. And I started developing mental disorders in my teen years. I know firsthand how problematic it is to accept having a mental illness and to accept treatment for it. I only have to use myself as an example to understand that when I had a severe episode in my 30s of major depression, I would not take an antidepressant. I was a psychiatrist. I knew what the treatment was for depression. I wouldn't take it because I thought that would mark me as a damaged person. I didn't want to be a damaged person. When I look back, it took me 12 years of having residual symptoms from the depression before I actually took an antidepressant, which made me remarkably better. It also turned out I had symptoms of PTSD, and it made those better because, you know, antidepressants aren't just for depression. They're really for anxiety disorders and also for PTSD. They work very well in all of those conditions. So it was only when I got on an antidepressant that I understood that I had PTSD as well, because my symptoms went away. It was a remarkable transformation. And I really have such a strong feeling for the resistance for not wanting to do it. If I'm a psychiatrist and it took me 12 years to think about taking an antidepressant medication because it meant to me that I was a damaged person if I took one, then I know I'm going to need to spend a lot of time with people to get them to the place where they can accept um, that, you know, that what they have doesn't make them into an unworthy person. That's why when I talk about mental illness, I like to stress all of the amazing things that people with mental illness can do. You know, my whole life's work is fueled by my early adverse childhood events. I'd have had a totally different life if it wasn't for adverse childhood events that drove me to do the work that I do. I know that trauma is a driving force in what we can accomplish. If we respect that and we are more open with ourselves and other people, that mental illness is pervasive. It affects people across the board. We all struggle. You may or may not have a diagnosable mental illness, but if you do, so what? You know, um, you can be a totally functional person who achieves a great deal in this world.
Thank you so much for sharing that, Dr. Cornels, and for your transparency. We do have a couple questions that have come in the chat. I'll read the first one. It is curious how some of us can build trust and rapport among people who inject drugs or people who use drugs living with HIV who may be distrustful of the healthcare system.
Yes. So, you know what? People are distrustful for the healthcare systems for many good reasons, which I won't review because it would take too long. But you're trying to establish a one-to-one relationship, a trust on a one-to-one basis. You can just assume people are distrustful. That's a safe assumption. And work from there. I think the beginning of being trusted by someone is showing an interest in their perspective, in what they have to say, and being able, that the same thing I tell my psychiatric resident, if you listen to what someone says and you repeat it back and say, so you're saying that when this happened, such and such occurred. Huh, I can see that must have been a really upsetting experience. You do that, you've done You've done such an incredible favor to the person that you're listening to. Active listening, yes, is a powerful tool. It is the single most powerful tool. That's how you gain trust. You gain trust by listening to what people say, hearing it, verifying it, um, and taking and not arguing about it. Patients' realities are their own realities. You don't need to get into a fight. I treated many psychotic people. Did I fight with them about whether their hallucinations were true or not? Absolutely not. Um, you know, that's a pointless fight that I wasn't going to win. Did I sometimes, when they started to have more insight, help them see that what they had was a delusion or hallucination? Yes, when they were ready, but not before they were ready to do that. I have treated people with constant auditory hallucinations who've run healthcare agencies and are able to do it despite all of their illness. So I am very impressed by what people can do, even when they have mental illness and substance use disorders.
Thank you. We have a couple others. They're coming in. As an academic and dentist in practice, I struggle with referrals down the WHO pyramid of care to local resources. Local resources change, people change jobs, etc. Do you have any suggestions on how to stay current and relevant with local professionals and peer council resources? In addition, suggestions on dynamic of rural versus urban referrals, especially in rural states without public transportation in many rural settings.
Right. So, what I did when I got to sub Saharan Africa was create a resource map. And it has to be constantly updated. Actually, I've done that my whole life, even when I started out as a psychiatric resident. And the whole team tries to keep it up to date. So it's important to know because everything is in a state of complete change. And because we know due to burnout and other things, it's even more in flux than it ever was. So in your own local community, it really helps to keep a list of what's changing, what's available, who the new providers are that may have, arrived, what the services are that might be available for free. When I ran a program for the severely mentally ill, I knew everything in the Washington Heights community neighborhood. It was a Dominican neighborhood, and I figured out every resource it had. That included teaching people to speak the English language and take the citizenship test, because once people became citizens, they had more access to resources. It included understanding where they went if they didn't have food. It included understanding how to get them temporarily out of an apartment with bed bugs, kill the bed bugs and let them get back in so they don't become completely homeless. It included every imaginable strategy. In rural settings, you need much more imaginative strategies about transportation, but fortunately, we do have more in the way of telemedicine. And I think that using electronic media has really given us a lot of new tools. When you think about what good came out of COVID, there isn't too much to say, but one thing that there is to say is that we now know how to communicate better remotely.
Yes. Here's another one. Can you comment on the challenge of culture in creating culturally response care in working with people in diverse communities?
Yes, what I've learned is that every culture is different, and every person in every culture is different from the overall culture. So my best strategy has always been to say, is to confess ignorance and ask people to explain it to me. I will say, for example, I've treated a lot of couples who come from all over the world. So I once had a couple, they both came from India. Um, and I said to them when they were talking about what they were arguing over, I said, I don't really understand Indian culture. Can you explain to me what the cultural norms are that would affect these things that we're talking about? That's how I learned that in India, parents walk into the bedrooms of their children while they're having sex, and that's considered just absolutely okay. But when people come to the US, um, they like the idea of parents not walking into their bedrooms, and suddenly they want to draw lines in a different place. Their relatives come to visit, they want to know, why are they locked out of the bedroom? Well, guess what? We have discovered there's a world you can live in where you don't have to let parents into your bedroom while you're having sex. I mean, that's like an extreme example, but people, cultural practices are very different. I don't assume I understand them. I try my best. I do a lot of reading. I try my best, but I always ask people to explain it to me. That's the concept of the culture of one. I know the person understands the culture better than I ever will.
Thank you. And we see that it's right at 12 o'clock, but Dr. Kronos has agreed to stay a little longer. And we do have another question. Any advice on addressing the desire to not prevent mania? Example, take mood stabilizer in triply diagnosed young adults.
Yeah. So it's a long battle. So that's what I'm trying to say. I actually have a niece right now who's suffering from bipolar disorder, a great niece. And it's been 3 years of me trying to intervene with her to get her to accept treatment. She gets psychotic during her bipolar episodes, and she believes that, all kinds of magical things are taking place, and that she has special powers and so on and so forth. And she gets really angry when you tell her none of these things are really true. And I actually had to spend a lot of time convincing her parents, because her parents are very religious, and her parents thought that it was a religious curse that their daughter developed bipolar disorder. I cannot tell you how much time it took me to convince her parents that no, it's not a religious problem. It's an illness.
Hmm.
Um, it's been 3 years. Just yesterday, I got an email from my niece, my great niece, saying, I realize all those psychotic things I thought are due to my bipolar illness. I think I'm going to try taking medicine and see if I can have a better life that way, because she was homeless. She suffered frostbite. I mean, I can't tell you the number of things that happened to her in her state of neglect. It is a long process, 3 years. And I can tell you, I have been so active in the care of this kid and the parents, understanding this kid. Um, and I'm amazed that you know what, you have to understand, we're in it for the long haul. It's not quick.
Thank you. We have another one. So I came across the factor of staying in your lane. I'm a licensed substance use counselor, but am working as a case manager. This is frustrating. How can you overcome lanes?
I don't stay in a lane. I practice defiance. I can tell you that everything I've ever done would have, that the best things I've done came from my defiance. Um, when someone asks me to do something genuinely stupid, but they're empowered to tell me to do it, I say, no, I'm not doing it. It's actually very interesting. People can ask you to do completely moronic things. And most people feel that because someone in authority is telling you, you have to do it. Well, suppose you don't do it. What's going to happen to you? Not that much. I'm a practicer of I don't do things that are stupid. And not very much has happened to me. I did eventually get myself fired from a job, but that was only because I didn't go along with a corrupt money scheme that the person I was working for had wanted to steal money in various ways, and I couldn't bring myself to steal money. That's what finally got me fired from a job, that I wouldn't steal money. But it wasn't anything that I did in my clinical practice. In my clinical practice, I got by just by doing what made sense. Don't be
Thank you.
passive.
Can you repeat that?
Don't be passive.
I don't see any other questions coming in, but thank you so much for today's presentation. My colleague has dropped the survey link in the chat for you all. So if you could please click that link, and it will also come through after today's presentation via Zoom. We invite you to join us September 13th for our next presentation. It will be called Youth HIV and Substance Use, Trends, Intersections, and Opportunities for Treatment. And it's September 13th. And my colleague has dropped that information in the chat, or we will very soon. But if there are no other questions, Dr. Cornos, we want to thank you again for your time today. We really appreciate this presentation. Um, and
And
we
thank you
will,
so much for inviting me, and thank you for listening. Thank you. I wish you all the best of luck in finding your own creative solutions to the crazy healthcare system we function in.
thank you.